Hello, everyone. We're going to recap pit crew CPR or high performance CPR. Pit crew CPR is how we operationalize the science. So, you should have watched the Science of CPR by Dr. Peter Kudenchuk, and we're going to work through how to operationalize the science, aka pit crew CPR. So there are some basics of pit crew CPR, and the fundamentals of pit crew CPR has mostly to do with knowing commands and giving the appropriate commands at the right time. If we're not on the same page when it comes to terminology, using crew resource management and closed loop communication, then the resuscitation is going to be chaotic, ineffective, and we're not going to achieve high performance CPR. So we must communicate effectively. So here are the commands that we're going to be using. Hover. What does hover mean? Well, it means you simply hover your hands over the patient's chest. We don't back up. When we're pausing for breaths, we don't back up, we hover. Everything hovers. When you switch CPR providers, you should hover. We pre-charge at a minute 45. You get the next person on deck, and when you say switch, you say switch and hover. Start CPR, stop CPR. Very straightforward. Rotate. We like to use switch and hover. Rotate works as well. And then check pulse. When we check a pulse, we should check the femoral after the initial assessment. During the initial assessment, we're going to be checking carotid. But when that on deck person is in position on deck, they should be feeling a femoral pulse with compressions. Analyzing clear, shock, no shock advised, shocking, shock delivered. And when we're performing CPR, you should expect people to count their compressions. So without an advanced airway, we're doing 30 to 2. So we'll count 27, 28, 29, 30. And when we're doing continuous, we do asynchronous breaths. We don't stop for CPR, but we count 8, 9, 10. Now that is without the ventilation timer on hand heavy. With the ventilation timer on hand heavy, you don't need to do that because it does it for you. And it's probably a little more accurate than we are. The countdown is extremely important. So at 30 seconds, we should be really preparing to get that person on deck. Whether you have to bump off the person on the airway to get them on deck, which is on the right side of the person that's currently doing CPR, and having them palpating a femoral pulse. All right. So that should generally begin around 30 seconds before 2 minutes. So at a minute 30. And then at a minute 45 or 15 seconds left, that's when you pre-charge. And you should announce pre-charging continuous CPR, because we work with a lot of different departments, and who they also have their own turnover rate, right? So they're struggling to keep people as well. And it's going to be impossible to train every single person at every single department as soon as they're on board. And it's just logistically impossible right now. So you have to communicate these things effectively, and you have to be loud. Now, who does the countdown? Generally, it's going to be the person operating hand heavy. They're the person with the timer, the 2-minute timer. And, hand heavy alerts you at a minute 45 when you're at a minute 45 and it's time to pre-charge. So that person is most of the time going to be the person on the monitor. All right. There's plenty of time for them to pull up hands heavy in between the 2 minutes and coordinate the whole resuscitation. If you have extra people on scene, that could be anybody. It could be the timer, the timekeeper. So whoever's standing back, getting a bird's eye view of the resuscitation. If you've got enough people on scene, that would be good. CPR positions and roles. So these are going to be pre-assigned prior to arrival. And they are pre-assigned because we have a certain way of doing it. It's based on the first arriving unit and the second arriving unit. Now, this is going to have to be modified if the fire department's on scene and already fulfills those rows, then great, those positions are assigned. And then when we come on scene, we're going to be filling our positions. So here are the positions and roles. The first are on scene. The first unit on scene, you need an assessor, one person who's going to feel for a pulse, see if it's present. Then you need a compressor. That person is going to immediately kneel by the patient's side, get in position, hover their hands. As soon as the assessor says no pulse, start CPR, they start CPR. And then a ventilator. So you've got the assessor on the patient's left, just to standardize things. That's the person with the monitor, generally going to be the paramedic. The compressor on the patient's right, hovering. And then the next position, when additional people show up on scene, the ventilator that's going to fill the airway position, and then the AED/monitor defibrillator. Now, this is essentially the assessor. All right, they are two different roles performed by the same person. It may be that when you get on scene, the fire department has someone assessing the patient, someone hovering, and someone starting CPR. And then when you arrive on scene, you're going to fill that role, and you're going to be on the AED or monitor defibrillator. And then a timekeeper. The timekeeper can be filled by the person on the monitor, or it can be filled by a totally separate person, someone independent whose only role is to keep track of time. Then on deck is the person that's up next for compressions. They're going to be that person. If you see in this picture right here, they are on deck to the compressor's right, filling a femoral pulse. So this is on deck right there, and then to the on deck position's left is the compressor. And then you've got airway. They've got two folks on airway up here. And what they do is have a paramedic intubate, confirm placement, secure the tube, and then switch it back off to a firefighter to ventilate. And then you have this would be your assessor / defibrillator monitor person right there. So the first crew on scene performs an assessment and starts CPR. This might seem a little mundane, a little nuanced, but the faster you can get hands on the chest, the better. So as soon as you walk up on scene, if you've got a patient that's laying there supine, lifeless, not conscious, not breathing normally, get in position. Number one, gets in position, hovers over the chest, and gets prepared to start CPR. Number two, walks up to the patient, palpates the carotid, says, no pulse, start CPR. Now, let's see what this looks like. And our goal is to keep it less than 10 seconds overall, which can be hard to do.
Sir? No pulse. Start CPR.
Pretty straightforward. Chest compression quality. Once you start CPR, if your CPR is insufficient, nothing else matters. And I promise you, and we've seen it, that when we perform picture-perfect CPR, patients can and they do survive. And perfection when it comes to chest compression quality is the goal. And it is the main goal when you are working a cardiac arrest victim. If you are not looking at the monitor, providing feedback, direct feedback to the CPR quality, if your goal is not to compress within 2 to 2.4 inches, and if you're not watching for recoil and you don't have perfect rate, then we're doing something wrong. That is our main goal. And our goal is to have picture perfect CPR at all cost. So body mechanics matter, and we should watch a video of good CPR. So let me stop right here. What is good CPR? It is the knees right next to the patient. It is the elbows locked out. You're not bending your elbows, pushing with your arms like this. Your elbows are locked. Your back is straight, and you're bending at the hips. All right? And with each compression, we want the palm of the hand coming up slightly off of the chest. Now, we want to position the monitor so that the person that's doing CPR can see it and they know how they're doing. But they might not know exactly what they're looking at if they haven't seen it before. So you, as the expert, the EMS provider on the scene, the one who's ultimately responsible for this, you're in charge of providing feedback, providing direct and loud feedback, and making sure that their CPR is perfect. There's really no excuse. If they're not doing great CPR, get someone else on deck. Get them in position. Go ahead and do your pre-charge, your switch and hover a little bit early. It's probably better that you do that you switch them out, than you not be afraid of upsetting somebody or hurting their feelings and letting them going, letting them keep performing unsatisfactory CPR. If there's an issue with their chest compression quality and they're not listening to feedback, the time to sort that out and provide coaching is after the resuscitation, if they're not listening to your feedback. So depth of at least 2 inches, 2 to 2.4 inches. You can see this through your accelerometer. Leaning on the chest is natural. It is unnatural to not lean. Our monitor has a metronome, should be set to 105 beats per minute. So as soon as you apply the pads, put the accelerometer on, it should start counting down. So you can see that, how he's bending at the hips. Shoulders are directly over top, perpendicular to the chest at 90 degrees. This will also reduce fatigue because pushing with your arms is more tired. You don't want them reaching out. You want their knees really close to the shoulder so that they're not having to reach out, because you can't do good CPR like that. Okay? So, you've arrived on scene. You're the first arriving crew. You've instructed your BLS partner to fulfill position 1. They have hovered, knees close to the patient. You, as the paramedic or the partner, has felt for a pulse, said no pulse, start CPR. And then what do you do? So number 1's doing CPR. Number 2 places the pads, anterior here, lateral here, and they pre-charge the monitor if you're a paramedic. Position 1 continues CPR while the monitor is pre-charging. All right? And then as soon as it's charged, you say hover, and then you announce shocking if it's shockable. All right? And you hit the button as soon as possible. Our goal is a pre-shock pause of less than 5 seconds and a post-shock pause of less than 5 seconds. So you have to be quick. All right? So your eyes are on the monitor, your fingers on that shock button. So pause and hover, VFib, shocking, hit the button, resume, just like that. Now, when the second crew arrives, that's when we feel more of the positions. For a sudden witnessed arrest, not due to asphyxia, our priority is CPR and defibrillation as soon as possible. And then when more people get on scene, you then fill the airway position. So as soon as the other folks get on scene, you fill the airway. So they place an airway adjunct and start BVM ventilations. And then they connect to end-tidal CO2. In fact, before you even start ventilating with that BVM, when you're setting it up, just take the Untitled CO2 connector, screw it in the monitor, and hit the button. But if they don't do it, your role as the person on the monitor is to make sure it gets done. All right, make sure that gets done. It is not acceptable to be ventilating a patient in 2022 without waveform capnography. All right, it is just not acceptable. It is the only objective way to know that the airway is patent and that the breaths are in fact going into the lungs. Now, once you feel 1, 2, and 3, you're doing 30 to 2. 30 compressions, 2 breaths. 30 compressions, 2 breaths. Number 1 is counting. The person that's doing CPR, 28, 29, 30, 27, 28, 29, 30. 2 breaths, quick breaths. Breath in, resume. Okay? And then you have an entire minute 45 before anything else major happens. Well, actually a minute 30. So in a minute 30, you're going to get someone on deck. All right? At a minute 45, pre-charge that monitor. That person that's on deck is finding that pulse. And if number 3 has to bump off, then bump off. So when they get on scene, they're going to start ventilations. The tendency that we have seen is to hyperventilate. We definitely don't hypoventilate, all right? How do we ensure that we're not hyperventilating? Well, when we're doing 30 to 2, it's not that big of a deal. The problem comes when we place an advanced airway and they can rhythmically squeeze that BVM. But there's still a problem with doing 30 to 2. Because the BVMs will deliver much more air than that patient needs. So instead of squeezing the BVM until both sides touch, you only need to squeeze 1/3 of the BVM, 1/3. In fact, you can pull your hand to the back of the BVM and just squeeze the back third of the BVM, the back third of the BVM. There are different ways to obtain a mass seal. You can do 2 thumbs down. You can do the C3 or CE technique. I'm not really sure if it looks like a CE, but that's what they call it. All right. Now, the problem with that is you frequently won't get a good seal. All right. Now, if I am doing the C3 technique, I want my BVM out to the side that my hand is not on, and I'm going to put some weight down so that I'm maintaining a seal on the opposite side of the face, and I'm pulling the jaw to the mask on the left side of the face, all right? Pulling that jaw, I'm doing a good, sturdy, heavy jaw lift or jaw thrust. Alternatively and preferentially, you do 2 thumbs down, you pull that head back, and you either squeeze the BVM with your chicken wing or you have someone else squeeze the BVM. Now, I've seen folks struggling to do the 2 thumbs down technique. Listen, if you're struggling and you're not getting breaths in because you're trying 2 thumbs down and you can't reach the BVM, then just do the C3 technique. And it's okay to do that if you're watching that monitor and you're using waveform capnography to confirm that your ventilations are going in. Now, how much breath do we give? Just enough to make the chest rise and fall. In fact, if you see the chest rise a bunch, you might be giving too much because it's not physiologic for the chest to rise visibly as much as we squeeze that BVM to make it do so. So barely, just a little bit of rise. And you want to give those breaths quickly. We want the person that's doing CPR to have blinders on with the person that's on airway, all right? I do not want the person that's on airway to control the pause, because what's happening is if we're doing CPR, we're counting 28, 29, 30, and then we hover and we stop. And the person that's on airway is doing something else. They're not paying attention. They're not listening. What am I going to do? Okay. I pause for 2 seconds. Let's resume. All right. And then you tell them, hey, pay attention. Listen up. So in this video, you can see what I was talking about, how you bring the BVM out to the side here to add some weight to this side of the mask. And with these fingers here, they're pulling the chin up. Now, if you're a smaller person, you might not be able to get a good seal. So you might have to have help. In fact, you might need two people with you on the airway. If it's cardiac arrest, the fire department's going to be on scene. You hold the seal, have them squeeze the bag. There's nothing, absolutely nothing wrong with that. And of course, we need Untitled CO2 in between here, connected to the monitor. Compressions and ventilations. So again, the compressor controls the ventilation pause. The compressor controls the ventilation pause. Let's see what this looks like.
One, 26, 27, 28, 29, 30.
Got good ventilations with that.
So the problem with this video is that he squeezed the BVM way much too hard, and the RA knows that. But it's kind of a good demonstration of what you don't want to do, and sometimes we need that. But the compressions were great. The pause was pretty short. And you know what? If I pause for a few seconds and that breath is going in, but it's been more than 2 seconds, I'm just going to keep doing CPR.
26, 27, 28, 29, 30.
Got good ventilations with that.
But you see how he delivered the breaths quickly, breath in, breath in. He could probably honestly do it a little bit faster. So this is BLS continuous.
8, 9, 10. 8, 9, 10.
1, 26, 27, 28, 29, 30.
Now, we do not do BLS continuous. We don't do asynchronous ventilations without an advanced airway. And there's a good reason for that. There's actually a survival advantage to pausing briefly to deliver 2 breaths. Believe it or not. I initially didn't believe it. I wanted to do asynchronous ventilations when it was the new thing out there. But recent evidence points towards actually 30 to 2 might be the same and possibly a little bit better. All right, so we've got all that going on. We've kept our initial assessment to less than 10 seconds. We're doing perfect CPR. We're giving feedback. We're monitoring Untitled CO2. We're doing 30 to 2. Now, let's imagine we just have 4 folks on scene. All right, we've had the airway position filled. All right, so number 3 was on airway. That was the 3rd person to get on scene. All right. We have number 4 who has started access. They've given an epi. And now we're coming up on a minute 45. The person on the monitor has already bumped off number 3 off of the airway and had them get on deck to the right of number 1. I don't care where they are at in the 30 to 2 cycle. If they're counting, if they're at 20 compressions and they're getting ready to deliver 2 breaths, I'm not concerned about it. We're at a minute 45, jump off, drop the BVM. Number 1 will just perform continuous CPR, right? They don't have to pause because no one's there to deliver breaths. So number 3 will jump around here. They're going to find a femoral pulse. Why a femoral pulse? Well, because that's where they're at. And there's a lot going on up here with the airway. You got a person here, you got a person here, you got a person here, maybe 2 or 3 people up here. And the femoral pulse is huge. It's like the size of your thumb. So it should be pretty easy to find. And I want to compel everybody to start palpating your own femoral pulse. If you're not accustomed to finding it, you need to practice on yourself. All right? So find the pulse with compressions. There should be a pulse with CPR as long as that person is performing CPR on the chest. You should be able to find a pulse. That way, as soon as that person stops CPR, you can say whether or not a pulse is present. It should be a affirmative yes. If you're on the monitor, let's say you're at a minute 45, you're looking at your see-through rhythm, or maybe when they delivered 2 breaths, you saw something, an organized rhythm, and your end-tidal CO2 increased a little bit. So you are expecting ROSC. You're expecting that patient to have a pulse. And then number 3 is finding that pulse. So you tell number 1 to stop CPR. You've got the monitor pre-charged. You've got a beautiful organized rhythm at a rate of 90. And number 3 is stuttering and stammering over whether or not a pulse is present. You just say resume CPR. All right, you just tell them to resume CPR. Now remember, we're also going to have an SpO2 probe on the finger, right? But you need to be able to see that waveform on the screen, and that's a problem that we don't frequently put that SpO2 waveform up on the screen. If you can do that, go ahead and do that. That'll kind of let you know if there's a pulse or not, because if there's not a pulse, or if there is a pulse, or if there's not a pulse, you won't get that consistent SpO2 pleth. You might get a little wavy baseline, but it's not going to be this pulsatile waveform. You just don't get that without a pulse. All right, so minute 45, traditional scenario is a minute 45. Number 3 is on deck. Then you have pre-charge. You announce that you're pre-charging, continue CPR, so that if people aren't familiar with pre-charge, they are aware of what you're doing. Make them continue CPR. Once it's charged at 2 minutes, assuming that number 3 is in position, if they're not in position ready to go, then you just keep going. Let number 1 keep doing CPR until number 3 is on deck. Then at 2 minutes, you say switch and hover. If it's VFib, you yell shocking, all right? And then you say resume. And number 3 should then become number 1. They will take over as the CPR provider. And then if you do this every minute 45, that's all you have to do. Every minute 45, all right? Number 4, the person that's down there on IVIO, then they can track their own medications on Hand Heavy if you want, if you're not too busy as number 2 on the monitor, or you can track it for them. All it takes is you hitting that epi button, and then it'll start an independent timer, and you give epi every 5 minutes. Every 5 minutes. Our new protocol is you give the first epi as soon as possible, then you give it every 5 minutes. Now, you might be wondering, well, Floyd, why did we bump number 3 off of the airway to get them on deck to find the pulse and take over CPR when we had 10 people on scene? Well, I agree. If you've got 10 people on scene, get you a Congo line of folks that can do CPR. You got plenty of firefighters, police on there. Get them on deck, right? Just say, who's up next for CPR? I need you on deck.